Use and interpretation of diagnostic tests. There is no such thing as a perfect diagnostic test. Test results give us test probabilities, not real probabilities. Test results have to be interpreted because they are affected by the following. How normal is DNED factors other than disease operating characteristics, sensitivity and specificity, prevalence of disease in the population. Normal values. Most tests provide quantitative results, i.e. a value on a continuous numerical scale. In order to classify quantitative results as normal or abnormal, it is necessary to deny a cutoff point. Many quantitative measurements in populations have a Gaussian or normal distribution. By convention, the normal range is denied as those values that encompass 95% of the population, or 2 standard deviations above and below the mean. This means that 2.5% of the normal population will have values above, and 2.5% will have values below the normal range. For this reason, it is more appropriate to talk about the reference range, rather than the normal range, Fig. 1.3. Test results in abnormal populations also have a Gaussian distribution, with a different mean and standard deviation. In some diseases there is no overlap between results from the abnormal and normal population. However, in many diseases there is overlap. In these circumstances, the greater the difference between the test result and the limits of the reference range, the higher the chance that the person has the disease. However, there are also situations in medicine when normal is abnormal and abnormal is normal. For example, in the context of a severe asthma attack, a normal PaCO2 is abnormal and means the patient has life-threatening asthma. Conversely, a low ferritin in a young menstruating woman is not considered to be abnormal at all. Laboratory results, e.g. cholesterol, thyroid-stimulating hormone, also vary from day to day in the same person in the absence of a real change because of biological variation and laboratory variation. The extent to which a blood test is allowed to vary before it has truly changed is called the critical difference. The critical difference is different for each test, and can be high 17% in the case of cholesterol and higher for some other tests. Factors other than disease that influence test results. A number of factors other than disease influence test results. Age, ethnicity, pregnancy, sex, spurious in vitro results. Box 1.3 gives some examples. Operating characteristics. Tests are also subject to operating characteristics. This refers to the way the test is performed. Patients need to be able to comply fully with some tests, such as spirometry, page 501, and if they cannot, the test result will be affected. Some tests are very dependent on the skill of the operator and are also affected by the patient's body habitus and clinical state. Ultrasound of the heart and abdomen are examples. A common mistake is when doctors refer to a test result as no abnormality detected, when, in fact, the report describes a technically difficult and incomplete scan that should more accurately be described as non-diagnostic. Some conditions are paroxysmal. For example, around half of patients with epilepsy have a normal standard electroencephalogram (EEG). A normal EEG therefore does not exclude epilepsy. On the other hand, around 10% of patients who do not have epilepsy have epileptiform discharges on their EEG. This is referred to as an incidental NDING. Incidental NDINGs are common in medicine, and are increasing in incidence with the greater availability of more sensitive tests. Test results should always be interpreted in the light of the patient's history and physical examination.